Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome, dear colleagues. Today we will continue our journey for understanding hematology. We started these courses by understanding the pathophysiology and physiology. حاسس إن في حاجة غلط في طيب، خلينا نكمل كده ونشوف الأخبار. We will continue our course. أظن كده هيبقى كويس، ها؟ طيب. We will continue our course in understanding of hematological malignancy. We started by understanding the malignancy of the lymphoid tissues. We finished most of it, and today we will talk about one of the very important subjects, which is the Hodgkin lymphoma. Hodgkin lymphoma is one of the two important subclasses of lymphoma. One is the Hodgkin, and by the way, the second is non-Hodgkin because they cannot join them into one disease category. So although that non-Hodgkin is different varieties, they cannot join into one big category. But the Hodgkin, all of the Hodgkin subclasses, either the classical or non-classical, shares a lot of similarities. That's why they can be mixed together into the Hodgkin disease. Dr. Hodgkin himself found the non-Hodgkin. يعني هو مش شافش بس الهودجكن، هو شاف. He found the Hodgkin and the non-Hodgkin. But he classifies this kind of disease, which is the Hodgkin disease, into one subclasses, and it is well known for more than 150 years. So this disease has been excessively examined. The second point in the Hodgkin lymphoma, it doesn't look like non-Hodgkin. Non-Hodgkin lymphoma is another disease. While Hodgkin lymphoma is a separate entity of disease. It has special markers, it has a special pathological appearance, and even it has a special outcome and a special clinical presentation. كل حاجة فيها special الهودجكن disease, different from most يعني of 90% of non-Hodgkin. Number two, non-Hodgkin disease is still a large amount of lymphomas. It is about 10% of lymphomas. And it can occur even in younger ages. So all of these things, and it responds very well to most of the chemotherapeutics. All of this makes it a very important point of disease that gives us good clarity about the epidemiology of this disease. It is about 0.5% of all cancers, and it has a bimodal distribution, as we have said before, and it has a slightly male predominance because it is more or less due to infectious cases, and it is related to inflammation. So we found it a little bit more in males. The risk factor of Hodgkin lymphoma is viral infection like Epstein-Barr and HIV, and immune suppression and autoimmune disease. This can give us an important view for how it presents and how it presents in the pathology view. In the pathology view, you find it is more or less some kind of inflammatory reactions besides the malignant manifestation. So Hodgkin lymphoma has a bimodal as it looks here in this curve. It has about one big mode at the 20s, and this is the most common one, and then another mode at the 70s. And as we can see, this is more for the nodular sclerosis, which is the most common cases. That's why its incidence is much more common than the other four forms of the Hodgkin lymphoma. The classical one shows a lot of cells. All of these cells are not malignant. If you take a biopsy like this for the diffuse large B-cell lymphoma or any kind of other lymphoma, all of these cells will be malignant. All of these cells will be malignant. But in Hodgkin lymphoma, this is very strange. The only malignant cells is this. This is the only malignant cells. So the malignant cells are very scarcity in this disease. Also, this disease is still a fatal disease if it's not treated. How it comes, we will understand now that although the rarity and the non-expansion of the malignant cells, but it is a malignant disease and it's still a fatal disease. It is CD30 positive, and this is very peculiar for this kind of disease because we have never seen a CD30 previously. In the previous lectures for lymphoma, we start always by discussing the best way of how we diagnose a small cell or large cell. But here we are not starting with this. We start with a peculiar pathological appearance under the microscope. The classical one, which is 95% of the whole kinds of Hodgkin lymphoma, have 4 subclasses, and the nodular lymphocyte predominant. Still lymphocyte is a lot, but there is another kind of malignant cells we will find, and it is CD20 positive, not CD30 positive. We will go into much more deep understanding of how this difference between the classical and the nodular lymphocyte predominant subclass. But now we can know that this is a bimodal appearance. Why there is bimodal appearance? Why it is much common in younger ages? This is actually because it is related to infection. If you recall, other causes of malignancies, such as Burkitt's lymphoma occurs, especially the endemic class that occurs due to Epstein-Barr virus occurs mostly in children and young adults. And this kind of malignancy also occurs in young adults. So I think this gives you a way why this case can occur in young adult, and at the same time it can occur in older ages when the genetics of the disease occurs, and thus another mode will occur. So this is very classical for Hodgkin lymphoma. Other kinds of non-Hodgkin lymphoma are not bimodal. It is also only unimodal. How to diagnose Hodgkin lymphoma? It is classically presented by as any malignancy and as any inflammation and as any autoimmune disease. Recall that all of these manifestations are not very strict for the lymphoma. So when we say someone coming with fever, drenching, night sweats, weight loss, this is things that is not related to lymphoma alone. It can occur due to any other autoimmune disease and due to any other inflammatory process. We call it sometimes the B symptoms if it is related to lymphoma, but in other conditions, we call it another name. For example, if it is inflammation, we call it a constitutional symptoms. If it is with autoimmune disease, we call it hypermetabolic manifestation. So all of this manifestation is due to rapid turnover of cells. This rapid turnover of cells produce a large amount of energy, heat occurs, and this is followed by stimulation of cytokines, releasing the sweat, and the weight loss is due to increasing of tissue necrosis factor and the other inflammatory process that will eventually lead to the presence of these symptoms. These symptoms occurs only in minority of cases, and these cases will be called B. And when these cases appears, this means the inflammatory and the malignant process is very severe, and thus the outcome of these patients who presented with these B symptoms are called having B or worse prognosis. But the most classical presentation is the painless lymphadenopathy. This is the most classical presentation, is painless lymphadenopathy. And this painless lymphadenopathy occurs mostly in the neck and the chest, more than the axilla, more than the abdomen, pelvis, and the inguinal. And this is from God's favor of us, because patients who are present to the painless lymph node, when he rapidly go to diagnose it and see a doctor, then it will be diagnosed as Hodgkin lymphoma in very early stage, and it can be treated early. I have diagnosed one case, maybe 20 years or more before, and he comes only by this silent lymph node, and is still living till now, and I meet him maybe a couple of years ago. So I want you to know that a painless lymphadenopathy warrants please, you can close the camera, please. Warrants the investigation. Never leave a patient coming with lymphadenopathy, and encourage your colleagues in other specialty. Whenever you see a patient coming with a silent lymph node, this may be a very dangerous condition. This may be a lymphoma. This may be a malignancy that if it's treated now, it will have a very good outcome similar to normal persons. If it is delayed just 3 or 4 months, it will come with another presentation and another outcome and a very worse outcome and a huge difference in the management, as we would see in this lecture or maybe in the next lecture. So a silent lymph node warrants a very, very rapid diagnostic procedures. Don't delay, don't give him antibiotics until it comes back. Start from scratch على طول ابدأ. Don't wait. What's classical for Hodgkin lymphoma also that it reacts a little bit different with some reaction, especially in Western countries, because it has the patients may have some alcohol intolerance, maybe it is a presenting symptoms. Patients may have a painful node at alcohol ingestion, though it is rare, but it's very pathognomonic for cases of Hodgkin lymphoma. Pruritus, fatigue, these cases similar to the B symptoms and also with the inflammatory and autoimmune and infectious causes. Then you must do a performance status assessment, how the patient reacts in the life, and the organ compression, if he has cough and shortness of breath, if he has chest pain, if he has severe vena cava obstruction, etc. Examination, lymphoid region, all lymph node groups, spleen, liver, systemic general examination of organ dysfunction, pressure symptoms. So as any general manifestation of any patients with lymphoproliferative disorder. Yes, we will do the general examination, the usual general examination. We call it thorough general examination, means a very systematic and very delicate general examination. Find any skin lesions, find any lymph node group. This is very important because sometimes you don't have the facility of doing everything. And sometimes when you put something in your notes, when the patient comes after 6 years, after 8 years, you will find that one of the lymph nodes was enlarged a little bit, the inguinal lymph node, and this is suspicious, and you will find the relapse occurs in it. So please do a very good systematic examination at the presentation. Do not miss this because you are going to do fancy CT scans and PET scans, because the examination anything cannot overcome the examination and the history, of course. As usual, the essential investigations are the CBC-SR, LDH, HIV and Epstein-Barr, hepatitis markers, and pregnancy test, because the patients take a huge chemotherapy and she may take radiotherapy. So these things are important in examination. The imaging has changed a lot. In my early residency, we are doing just CT scans of the chest and abdomen, and sometimes for the neck and for the head, if it is possible. And usually we do for the neck and for the chest and the abdomen. Now we are doing PET scan and MRI. The PET scan is no longer an auxiliary or added investigation. It becomes now an integral part of the line of the treatment. You cannot, in the new era of treating Hodgkin lymphoma, you cannot go without using PET scan, because decisions of the continuation and the shifting of chemotherapy and or radiotherapy depends on this. So the PET scan becomes now an essential integral part of this disease follow-up and the treatment. What is more indicating of the importance, what's indicating of the much importance of this scan in the treatment, that we are not doing it after the 3 or 4th cycle as in non-Hodgkin lymphoma. We do it usually after 2 cycles. So this gives you how much this kind of investigation is important. MRI is used in selected cases with contrast unless contraindicated. So MRI is not used much more in the hematological malignancy, unless in some peculiar cases like multiple myeloma. But MRI, sometimes it is used in Hodgkin and non-Hodgkin lymphoma in cases we cannot use PET scan due to any cause. If the FDG PET CT is used and we need to do some CT scan with contrast, we can do the CT component of conventional CT scan. If PET scan, we can do the CT scan even with contrast. يعني ممكن اعمله بالكونتراست بلس الاف دي جي كونتراست اللي هو الراديو ايزوتوب. to use CT with contrast or not. Usually now we do not use CT with contrast because the exposure to contrast and the expense of the contrast, we just do the BT because PET scan is better than doing the CT. But still some colleagues want to do at least first time with the CT with contrast because it gives a very good importance about the size of the tumors and if we need to take the biopsy and these things. Even it is not very hot in the PET scan because PET scan has some issues. We already know some of this. We will come to one of these issues now. Is that the brown fat activation and false positive. It is very important not to be very optimistic about the PET scan results because of PET scan, there are a lot of consideration when you are interpreting PET scan. This is a rule for all of us. Always judge your clinical sense and your expertise when you are dealing with hematological malignancy, depending on the PET CT and CT scans, and for the new era, we are depending on the AI. Because these things gives a very bright result that you think that they are right and you are wrong. So follow your instinct. انت داخليا شايف العيان نورمال والبيت سكان مديني 4 level 4 لا revise yourself, ask a colleague, send it to another radiologist. These things must be interpreted in a multidisciplinary team because something like this, which is called brown fat activation, may give a very strong impulse and it is false positive. So what's brown fat? All of us knows about this brown fat and white fat. Brown fat is very metabolically active and it can burn glucose for heat. So if you give this FDG, which is the radioisotope glucose, it can take this radioisotope glucose and as if it is tumor and burn it, and hence it will give you a very shining under the PET scan to that degree, to that extent that you can think it is a tumor, and some deal it with a tumor, and which is very common in the neck, supraclavicular area, paravertebral areas. You can find a lot of shiny areas. I know now the radiologist becomes very good at it, but sometimes they are not sure. So you give you that is metabolically active, and you see if it is metabolically active due to tumor or no due to inflammation or due to brown fat only. So it is very important every now and then to have a colleague's opinion to discuss the areas which is usually not infiltrated by lymph. How it comes to have infiltrated by this? This is no secondaries in Hodgkin lymphoma. It infiltrates only very rarely to infiltrate the organs. And how it comes at the paravertebral area, it doesn't infiltrate bones. So with a normal bone marrow, for example. So be very cautious while you are interpreting this. It is prevalent in cold exposure, young or anxious patient, and these things are very common in the PET CT theaters. In PET CT theaters, the patient sometimes wears a gown, and the air condition is very strong, and maybe 18 or less, and the patient is extremely anxious, and he's young because it is bimodal, and all of this in favor of having very strong impulse from the brown fat. So brown fat avidly takes the FDG and it becomes very positive falsely. So how to reduce the brown fat uptake? First, pre-scan preparation, make the patient warm, fasting, do not give too carb, and give him some beta blocker to decrease anxiousness and decrease sympathetic activation of the brown fat. Try to do this. And during the scan, make the patients very warm and sometimes give sedation to decrease the stress, which stress increases activations. If maybe sometime we can discuss these things around the PET CT, and this is a possibility of false and negative results, and I can ask a colleague to maybe share us for this. Sometimes in some selected cases, and actually this is not in selected cases, this is for the NCCN guidelines saying in selected cases, but for us, usually we are doing this. We do pulmonary function test, and sometimes we do DELICO, but DELICO only for those who are going to do under transplant, because DELICO is using for the lung capacity for excretion of carbon dioxide, which is very sensitive for the alveolar membrane activity and diffusion capacity. So if it is not diffusing carbon dioxide well, this means the patient has marked diffusion problem, and usually he cannot withstand further chemotherapy containing bleomycin or other things that will destroy the lung, and usually he doesn't support to have a transplant. The cardiac is a part of integral part of treatment of any hematological malignancy, because anthracycline is mostly in all of the chemotherapies. So cardiac assessment is very important. Counseling for fertility, psychosocial and smoking cessation, and fertility preservation by semen preservation or in vitro fertilization after, if the patient is already married, and ovarian tissue oocyte preservation. All of this is important. In previous lectures of lymphoma, we didn't discuss this and we didn't talk about this too much. But now we are stressing upon them. This is simply because we are dealing with a much younger patients in the bimodal presentation of Hodgkin. So we have number one. Number two, we have a very good outcome. Patients may live for many, many years, maybe live for 20 years. So there is a very good possibility that this lady with Hodgkin lymphoma or this man with Hodgkin lymphoma may want to have children. So if we are not discussing this very well in our countries to patients who are old, maybe 60, 70 years old, it is not applicable to have ovarian tissue preservation for a menopause lady, or someone who is 70 years old, they have 5 children. It's nonsense to talk about this. But in young patient who's 20 years old, who will have extensive amount of chemotherapy and radiotherapy, there's a possibility of azoospermia. So fertility preservation here is a must, and you must discuss it with the patient if it is available. And if it is not available, you must discuss it with the patient, because the treatment mostly may have a deleterious effect on the oogenesis or spermatogenesis. So you must do this discussion. Now you do CT scan for someone coming with a lymph node enlargement, some with B symptoms or not, or pressure symptoms, and now you think that doing some CBC and CBSR and radiation, some viral investigation, some pregnancy test, and now you think that he has a lymphoma. You must, because lymphoma is a malignancy, you must have a biopsy. Of course, fine needle aspiration is not good. Excisional biopsy is the recommended one. Excisional biopsy means the excision, to take the whole node, because architecture changes is very important in comparison of different subclasses of Hodgkin lymphoma. But sometimes a core needle, which is about of the lymph node, sometimes if you do an adequate immunohistochemical examination would be good. But the core needle biopsy is not good as well. Nowadays, there is some interest in some surgeons and in some radio diagnosis and radio interventionists to do a good way to take a very good sum of lymph node without hurting the patients, to be taken under light anesthesia and local, because this can take a good core of the lymph node without harming the patients. So this may be a very good one. So nowadays, more or less, if the patients like Hodgkin lymphoma presented by external lymph node, we always find this problem when we are facing non-Hodgkin lymphoma patients who are having presented with the intestinal mass, para-aortic mass, sometimes masses which cannot be taken adequately. Some paratracheal mass needs mediastinal. Most of the patients with non-Hodgkin lymphoma are very challenging, because many times we cannot take the biopsy. But in Hodgkin lymphoma, it comes with mostly with cervical lymph node. So if you say, yeah, doctor, I cannot take the lymph node biopsy, you are wrong. Patient usually coming with good CBC, good BT and BTT, and a very huge one or apparent lymph node in the cervix, cervical region. So why you take the biopsy? You must take the biopsy and be very rapid to taking the biopsy. And if you take a whole biopsy, or what we call the excisional biopsy, you can find a whole lymph node, or we call it in toto, and we take the whole lymph node. Now you can do a lot of examination, pathological and histochemical on it, immunohistochemistry, and you can diagnose it very, very accurately, the type and subtype of the Hodgkin lymphoma. Before, in my residency, it was very common to have bone marrow examination because we didn't have PET scan. But now we have PET scan. He, in a quiet way, he gives you the diagnosis of is it infiltrating the bone marrow or not. But still, bone marrow is still indicated in some special indications. For example, if there is unexplained cytopenias apart from anemia, anemia alone is not an indication, but the patient has thrombocytopenia, the patients may have leukopenia, unexplained, you can, and the negative PET scan, so it's better to do the bone marrow, maybe the bone marrow is fibrotic. So it may give you another insight about the disease possibilities. Marrow involvement is suspected if there are 3 more skeletal PET-CT lesions in the bone marrow, then it is important to think about this kind of disease. What are the types of Hodgkin lymphoma? We have said that there is classical Hodgkin lymphoma and non-classical or atypical Hodgkin lymphoma. The classical Hodgkin lymphoma, as we can see in the graph, there is nodular sclerosis, about 70%, mixed cellularity, about 20%. We will understand everyone in details. Lymphocyte rich, 5%, lymphocyte depleted, 1%. This is the classical, and this classical is 95%. And still 5% of another form called nodular lymphocyte predominant. We will understand every word, don't worry. And this nodular lymphocyte predominant kind of Hodgkin lymphoma, it have 2 names according to the WHO 5th edition classification. We call it nodular lymphocyte predominant Hodgkin lymphoma, or NLBHL. This is very common. But we have said that there is another kind of classification which is called the ICC, International Consensus. The international consensus says that it may be B-cell nodular lymphocyte predominant B-cell lymphoma. Both terms are exactly the same. They are the same disease. But usually we use the first term, nodular lymphocyte predominant Hodgkin lymphoma. It is the same as nodular lymphocyte predominant B-cell lymphoma. They are the same. But you can see both terms in different literature, so don't worry about this. They are depending on which type of classification they are using. There is another class which is very minority, but is still important to notice, which is called the gray zone lymphoma. And from its name, you can know what it's dealing about. It's a kind of lymphoma that we cannot show it is Hodgkin or non-Hodgkin, so we call it a gray zone. That some will put it into Hodgkin's and some will put it into non-Hodgkin. And it is related to a special kind of diffuse large B-cell lymphoma, and it will be very easy to remember, as we will know now. The immunophenotyping is very classical for Hodgkin lymphoma. I think all of us is accustomed with the CD15 and CD30 positivity. These forms are not for B, not for T, not for any kind of malignancy. So 15 and 30. It is not a B marker. It is not a T marker. It is something very peculiar for this kind of disease. PAX5 may be weak, which is an early form of markers. CD3 is negative. CD20 is negative. So it doesn't carry. But this is for the malignant cells. But the non-malignant cells are surrounding the malignant cells. The malignant cells is minority. The other malignant cells are mature looking and normal B lymphocytes. It will be very strong for CD20 and for 79B. This will be very strong. But these peculiar malignant cells, which is the Reed-Sternberg cells, will be negative for all of this and only positive for the 15 and the 30. But on the contrary, the nodular lymphocyte predominant Hodgkin lymphoma, which is the non-classical form, have CD20 positivity rather than CD30, and CD30 is negative. So this is very distinctive type of Hodgkin lymphoma. It doesn't carry the classical Hodgkin lymphoma immunophenotyping. On the contrary, it carries the non-classical forms of non-Hodgkin lymphoma. And even this subclass can be treated with anti-CD20. So this kind of lymphoma. So why we carry them with lymphoma, although they look with Hodgkin, although they look like non-Hodgkin, we will not understand now. There are other markers for special situations, like Epstein-Barr, including lesion and cytohybridization, or called EBER-ICH, which is from its complex names. You can understand that this EBER is related to Epstein-Barr. So we know that Hodgkin lymphoma can be induced by Epstein-Barr virus, so it is related. But there are a lot of diseases in the Hodgkin era, non-Hodgkin era, is also positive for this marker. That's why the Hodgkin lymphoma can be misdiagnosed and have a very good differential diagnosis, very large differential diagnosis with other classes of non-Hodgkin lymphoma, with some class of non-Hodgkin lymphoma. We can expand the panel markers for the MUM and the OCT. We know that the MUM, we said this before, MUM, this is myeloma related, which is a post-germinal center marker, which is with the IRF, but this is not important only if the case looks like non-Hodgkin lymphoma, like nodular lymphocyte predominant. So in these cases, we can expand the markers to diagnose if it is Hodgkin or non-Hodgkin subclass. So it is always comes in questions and always comes into problem. Is it a classical Hodgkin lymphoma or it is nodular lymphocyte predominant Hodgkin lymphoma? We'll understand the difference now. Of course, the malignant cells, we took it even in the undergraduate, the malignant cells of the classical Hodgkin lymphoma is called Reed-Sternberg cells, and both of them are independently described the cells, so they put both of the scientists' name in the same name. So, and now it has been abbreviated as RSHL, Reed-Sternberg Hodgkin lymphoma cell. It has can be two nucleus, different shapes of nucleus according to subtypes, and classically described as owl eyes, زي عين الأول اللي هو الظبي، الظباء الكبيرة بتبقى عينيها كده كأنها two eyes. So because of these two nuclei, while a nodular lymphocyte predominant, it is called popcorn cells because it is have a large single nucleus and its cytoplasm is surrounded and there's beads inside the cytoplasm and it looks like a popcorn when they look for it, popcorn. And I don't know what there is fantasy with describing the diseases with food. Starting from my, when I'm very young, when I joined the medical school, then everything is, they describe it with some kind of food. I don't know why this is diseases and fatal diseases, and they wanted to always anchovy sauce and these things. I don't know why. So if you, any one of you have some idea why they call the diseases with similar to some food things, I don't know why. The background for the classical Hodgkin lymphoma is mixed inflammatory infiltrates, eosinophils with histiocytes, but in the nodular lymphocyte predominant, it looks like there are nodules, which is abundant of the lymphocyte. So it is nodules and lymphocyte. While the classical Hodgkin lymphoma, there are mix of eosinophils, histocytes, and B cells and T cells, because we have said before it is something like inflammation rather than malignancy. Where under the microscope, it looks like inflammation. And also, if there is no Reed-Sternberg cells, we will never can know that this is malignancy, because this is the only pathognomonic feature is the Reed-Sternberg cells or RS cells. The histology, there are four subtypes we have discussed and discuss more in details. The nodular lymphocyte predominant is only one type, which has a nodular growth and occasionally diffuse, but usually nodules, and usually forms the popcorn cells in the center, which is CD20 and CD45 positive, and 30 and 15 negative, while the classical is 30 and 15 positive, and 20 is weak or negative. And there's Epstein-Barr inclusion bodies present in the immune phenotyping for the classical. We cannot mix between them. It is very difficult to mix between classical and non-classical. The differential diagnosis is very obvious, but the problem is the differential diagnosis of is it lymphoma, Hodgkin or non-Hodgkin? This is another issue. Let's talk about everyone in much details. The nodular lymphocyte predominant, which is a non-classical, we will find the large neoplastic cells, which actually looks like popcorn فعلا, looks like popcorn, folded irregularity contoured nuclei and small nucleoli in a background of small lymphocytes, and in the great pathology or general pathology, you will find it in nodular form. So a distinct B-cell neoplasm with indolent behavior. This has an indolent very good behavior. الدefinition بتاعها indolent behavior with popcorn cells. Epidemiology, it's about 5% of all Hodgkin lymphoma conditions. Site cervical axillary, usually lymph nodes, and the pathology is the lymphocyte predominant cells or popcorn cells, CD20 positive and CD30 and 15 negative. And clinical, which is usually painless lymphocyte and rarely B symptoms, very similar to classical Hodgkin in this. And prognosis is excellent. And the treatment is usually by localized therapy and rituximab. Why rituximab in this case? Because it is CD20 positive, it is CD30 negative. We cannot use Brentuximab. We can only use rituximab. So it is very important. It comes in many, many questions. And even if you are keen to ask about all of the markers, you can miss this type very good, because CD30 sometimes is positive. So if you diagnose it as classical subclass, you will treat it aggressively and it is more or less benign course. Number two, you will treat by Brentuximab, which is extremely toxic, and you will miss the treatment of rituximab, which is less toxic. So it is very important that this kind, which is also 5% of all Hodgkin lymphoma, but it wants to be very, very, very cautious when you are diagnosing Hodgkin lymphoma, because even this subclass of Reed-Sternberg cells, which is the popcorn cells, sometimes looks like other cells, like lacunar cells, for example, or non-classical Reed-Sternberg cells in the classical form. It doesn't appear, looks like the classical form double eye or Owl's eye or double nuclei. So it's very important. If the case is subjected to have this nodular lymphocyte predominant form, it's very important to concentrate to diagnose it. So this for the 5% classical. I started with it because the other forms will take much more time. So it's very important to know this. All the four subclasses of the classical, which is 95%, have this very peculiar cells, which is called Reed-Sternberg cells or HRS cells, surrounded by inflammation, which is mixed between a lot of kinds of tissues and cells. So it makes the classical form divided into 4 more types. The HR cells, which is Hodgkin Reed-Sternberg cells, makes about 0.1 to 10% of the cells in the tumor. This is extremely strange. When you see a tumor, you will find 90% of the cells under microscope are of the tumor. But what this kind of tumor that the malignant cells present is only 10% and is still fatal disease and it needs aggressive management. All of this is because this disease of an inflammatory rather than of tumorigenesis form. The inflammatory process plays an important role in the flourishing of these malignant cells and into the development of further and further infiltration of tissues and hence the mortality of the patients. The Epstein-Barr virus may be positive in about quarter to 1/2 of the cells. So it is an important link between infection and this adds more to the theory of infectious spores of Hodgkin lymphoma. And although this is characteristics manifestation, is still this kind of lymphoma passes into other 4 subclasses, which is a classical into 4 subclasses. The first and the most common and the most abundant, it is 70% of it, the most abundant kind. أكتر نوع هتشوفه في الهودجكن lymphoma is the nodular sclerosis. And from its name, it is very easy to understand what is called this. There are a lot of presented as nodules under large microscope or large field. We call it gross microscopy. And there's a lot of fibrosis, which is the pink partitions between the nodules. This is very classical for this kind. So most common subtype, this fibrotic bands or the sclerotic band, dividing lymphoid tissue into nodules. And inside the nodules, when we go by the microscope, more we look in microscope, more concentration on the microscope, 400x, you can see the Reed Reed-Sternberg cells. It mostly occurs in the young adults, and the histology, it is nodular architecture with broad collagen bands. Immunophenotyping is the classical. CD30 and 15 is usually positive, and CD20 and CD45 is negative, in contrast to nodular lymphocyte predominant subclass. Genetic in the molecular, there's some problem in the ninth chromosome, especially the P24.1, 24.1, which is carrying a very important marker, which is a marker of called programmed death ligand 1 and 2. So this will help to call for the T lymphocyte and to make paralysis of the T lymphocytes, because the programmed death 1 makes a strong impulse to inhibit the T cell function. So the PD make the malignant cells flourish, and at the same time causing hypnotization or paralysis of the T lymphocytes. Usually it comes with a mediastinal mass. This classical form, it doesn't come with a classical cervical lymph node. It comes with the cervical lymph node and with a mediastinal mass. So it goes into a very broad differential diagnosis of Hodgkin lymphomas and other kinds of malignancies and other kinds of inflammatory processes that comes with mediastinal mass. And the mediastinal mass, so the patient will come with a mediastinal syndrome, coming with a superior vena cava obstruction, facial swelling, jugular venous, congested non-pulsating jugular veins, and when elevating the hands, the congestion increases of the face, and the dullness over the percussion of the, and sometimes dysphagia, and sometimes, of course, hoarseness of voice or problems with the respiration. It has a good prognosis with the treatment, and usually young female and having a bulky mediastinal mass, you must think at the time of the nodular sclerosis Hodgkin lymphoma, classical Hodgkin lymphoma. The second one is called mixed cellularity, and from its name, it is mixed cellularity, a mix of cellulars. And because it is not sclerotic, there's not a lot of sclerosis. So it is subtype of classes of Hodgkin lymphoma. It's about 20%. There is polymorphous inflammatory background, lymphocyte, eosinophils, plasma cells, histiocytes. So that's why it is called mixed cellularity. So mixed cellularity, not because of the malignant cells are mixed types of malignant cells, but because it is a case of mixed background of mixed types of cells. It is about 20% of the cases, and usually it comes with the lymph nodes. Histology, diffuse interfollicular Reed-Sternberg cells, but less than 10%, in a polymorphous background, and the flow أو immunohistochemistry, CD30, CD15, maybe plus or minus, CD20, and the Epstein-Barr virus is positive. And the diagnosis by lymph node biopsy, and the treatment, as we will see the treatment, and the prognosis, it is very good prognosis. So the most common classes of Hodgkin lymphoma are very good prognosis. So 5% of nodular lymphocyte predominant, it is extremely good prognosis, but treated by rituximab and radiotherapy. The nodular sclerosis subclasses is coming with mediastinal mass, and it is a good prognosis. The mixed cellularity, which is 20%, now we are talking about 95%. Still 5% or 6% only, which have some mixed outcome. So Hodgkin lymphoma is one of the very best diseases to be treated. But if you treat them right, if you treat them in the right way, if you are not very afraid of giving chemotherapy for these patients, because this patient, if not treated quite well from the start, they usually relapse. And when patients usually relapse, when a patient relapses in lymphoma, usually his response will become bad. So here in the mixed cellularity, you can see the difference between this form and this form. So these are very similar cells to each other. Very fine amount of other kind of cells, mainly B cells and some other cells, but not as much as this. There are different classes of cells and mixes with some collagen in between and some fibrosis. This is called mixed cellularity subclass. It's about 20% of Hodgkin lymphoma. The third most common, or the fourth most common, will be the lymphocyte rich, and you will find a lot of lymphocytes everywhere. Lymphocytes. These lymphocytes are normal lymphocytes. They are inflammatory lymphocytes. So there is scattered Reed-Sternberg cells and Hodgkin lymphoma in a quiet, monotonous infiltrates comprising small lymphocytes. There are not different types of subclasses of inflammation here. The only, what are present only here is only mature lymphocytes. So it is not common disease, about 5% only, and mainly peripheral lymph node, especially cervical, and histology nodules or diffuse pattern, and renal cells within lymphoid nodules, no granulocytes, ما فيش أي infiltration of other cells, and the cells is CD30 and CD15 positive and 20 negative, and molecular features as any classical form, nuclear factor kappa beta. Will come to this in more details, and it's diagnosed by the biopsy, and the treatment is a good prognosis. So still, most of the cases of Hodgkin lymphoma is a good prognosis. Maybe the only one which is very rare, and it will be very bad luck for the patient to come with, is the lymphocyte depleted. You can see here, there are some Reed-Sternberg cells, there is no and marked fibrosis, and there is no background. This is rare subclass. It is less than 2 or 1%. And the sites usually subdiaphragmatic lymph nodes, and the immunohistochemistry is 30 and 15, and the clinical percentage will be symptoms, and the prognosis is poor than other classical Hodgkin lymphoma, and of course, than the nodular lymphocyte predominant non-classical. And there's diffuse fibrosis, some fibroblastic stroma, histiocytes, reticular sheets of pleomorphic Reed-Sternberg cells. This is aggressive disease. This is, and presents only, alhamdulillah, 1%. So this is a portrait of all differences between them. The most important is that the prognosis is excellent in most of them, except maybe of the mixed cellularity, and for the lymphocyte depleted, it is most worse of them. But most of the non-classical and the classical are very good, except maybe for the mixed cellularity and for the moderate, and for the lymphocyte depleted is worse. I wanted to concentrate that the CD30 is positive in all except the lymphocyte predominant, nodular lymphocyte predominant, and CD20 is strongly positive in nodular lymphocyte predominant, non-classical, and very weak in other classical forms. This is very important difference, this CD20 and CD30 differences. I will share this with you, inshallah, on the Telegram channel. What is the pathogenesis? As before, we discussed this before, in all malignancies, there is some integration between some genetic disease and some fault during the development of the cells. And the pathogenesis here is solely depend on this of the inhibiting the, because it is inflammation. But this inflammation must come and destroy any malignant cells. But how these malignant cells escape the destruction by the inflammatory cells? By altering the PDL pathway. What is PDL? As we said before, the programmed this one ligand, this is a decoy protein. This decoy protein will be attached to the cytotoxic T cells receptor, so BD1 receptor and BD2 receptor, and tell it and give it a message. This message called "Do not eat me." So it tells the cells "Do not eat me." So what the what is the RS cells, Reed-Sternberg cells, will do? It will over and over and over express this "Do not eat me" signal. It will present it on the surface and say to the cytotoxic "Do not eat me" cells. So the Reed-Sternberg cells will be surrounded by a lot of cells. Some of them are T, some of them are B, some of the other inflammatory, because it is induced by inflammation, and send the message "Do not eat me" cells. And what happens is strange. The T cells will apply for this. It will not eat it because the T cells will respect this message. And at the same time, it will stimulate a similar mechanism of increasing the cytokine features that will attract more and more inflammatory cells, and it will lead to the growth and the development of these malignant cells. So HR cells derived from the germinal center B cells. No immunoglobulin production or somatic mutation. There's some fault in the metabolism بتاعها. But what it happens, it will have activation of the JAK-STAT, which is the mechanism of the transcription in the cells. So it will increase the JAK2 and STAT pathway. And at the same time, it will enhance the programmed this gene and increase expression of the ligand L1 and L2. And this will lead to more and more stimulation of the JAK system. And at the same time, it will be expressed over the surface and send do not eat me signal to the cytotoxic T cells. And that's why, although Reed-Sternberg cells is surrounded by all of these cells, but it, at the same time, it is not destroyed because it plays an orchestrating role to inhibit the T helper cells by sending the BDL program this one ligand, and also in front of it the CD40 receptor, and send a do not eat me cells, do not eat me signal to the other inflammatory cells, especially the T cytotoxic cells. Also, T helper plays a role. Treg will inhibit also the cytotoxic T cells, so it will orchestrate all of the immune system to prevent its destruction. How to stage Hodgkin lymphoma? As any staging, usually as an upper stage, there will be, if there's one tumor over the diaphragm, it will be called 1+1. If it is two groups over the diaphragm, above the diaphragm, it will close to class 2. If there are groups of lymph nodes above and below the diaphragm, it will be called class 3. If it is infiltrating any other tissues, including the bone marrow, it will be called class 4. Of course, the 3 and 4 are very bad prognosis class, while 1 and 2 are very good prognosis class. Bulky mass, if the thoracic ratio, as we have discussed before, more than the third of the nodes. Letter E means extranodal, contiguous extranodal extension. Letter B means P symptoms, and letter A means no P symptoms, or good prognosis. This is called an Ann Arbor staging system with Cotswolds modification. It adds a lot of modification. This modification helps more and more to stratify the disease. And let's take a look about this modification. It will be helpful. If we add E, this means an extranodal contiguous. For example, if it is in the neck, if it is infiltrating in the neck, the tissue beside the lymph node, it's called extranodal. For example, if it comes to the tissues beside it, or it comes into non-lymph node area, like spleen, like thymus, like alveolar link. This is called also stage 1E. So 1E may be extra lymphatic site or the lymph node and its extra lymphatic site. In one group, on one side of the diaphragm, this is called stage 1E. Stage 2 also may be two groups on the same side of the diaphragm, and at the same time, it can also having contiguous extension. So it is called stage 2E. If it has a stage 2E. And we can add number according to the group, number of the group. So if it involves more than 2 groups, 3 groups, we will call it stage 2, 3. If it involves 4 groups, for example, both axillary and both neck sides, this will be 4 groups. So we'll call it 2, 4. But for simplicity, any amount of groups, more than 2, more than 1, on the one side of the diaphragm, we call it stage 2. But of course, more and more groups mean worse and worse outcome. Stage 3 has a peculiar condition because stage 3 divided into 1 or 2 according not to the amount of the lymph node groups are affected, but about the site of this lymph node. So stage 3-1 involve lymph node regions on both sides of the diaphragm. Abdominal disease is limited to the upper abdomen. But if the abdominal disease is involving the lower abdomen as well, or lower abdomen alone, this is called the stage 2, and this is bad prognosis. Look, it is like an expansion of the inflammation. As we have said before, the disease starts usually in the cervix, and in some classes it starts in the mediastinum. So mostly above the diaphragm. If it involves the below the diaphragm, means extended downward and involve only the upper half of the diaphragm, just upper half of the abdomen, it's called the stage 3-1. But if it involves also the lymph nodes inside the below the diaphragm, below the umbilicus يعني, or inside the pelvis, it is called the stage 3-2. Still, if it is having extranodal or not, if having the spleen, we will add S. Why all of this much يعني complicated adds to the Ann Arbor staging? All of this because more and more nodes means the worse and worse prognosis. We can add A if there's no symptoms. We can add B if there's one or more of the B symptoms. We can add X if this bulky disease, that's to say more than 1/3 of the diameter of the thorax, the diameter, or more than 10 centimeters or 7 centimeters, this is considered bulky disease. E if there's involvement of single extranodal lymph node. So this is, you can now do a PET scan or CT scan and the examination, and you can say, wallahi, there is stage 2, stage 2E, stage 2E B, stage 2EA. It's according to the amount of lymph nodes that appears in the PET scan. Is this enough for knowing the prognosis of the patient? To a special extent, yes, because the prognostic assessment depends only many things. One of them is the prognosis assessment in Hodgkin lymphoma according to the Ann Arbor stage. If it is stage 1 or 2, the cure rate is 90%. So it's early stage Hodgkin lymphoma will be 90%. Advanced disease, Hodgkin lymphoma, the outcome is worse, less, and it needs much more chemotherapy. It is 75%. But there is a special prognostic scan for early stage and special prognostic indications again for the advanced stage. We'll divide it according, we will see just right now. What is the classification for the early stage? For the early stage, it depends on the presence or absence of B symptoms. If it is class 1, it is Ann Arbor 1, stage 1 or 2, still A, and there is no bulky or mediastinal mass, no bulky mediastinal mass or less than 10 centimeters adenopathy, and there is no ESR increase or less than 3 sites, this is called the favorable disease. But if it has any of the bulky disease or ESR high, this is called unfavorable disease. That is to say, even stage 1 and 2A, they have no B symptoms, still there are some other indications to say if they are favorable or not favorable. Why we are doing this? Because the treatment will depend on this classification. So I know it becomes more and more and more complicated, but I wanted to know that these things are built on each other. First, to know Ann Arbor. Now to know if there is mediastinal bulky mass or large in lymphadenopathy mass more than 10 centimeters. Then you understand how many groups are involved. Then you know what is the ESR of the patient. And then collect this together to know the outcome of the patient is a favorable or non-favorable prognosis. But still the patient is 1B or 2B, that's to say he has B symptoms. This means that this patient is having unfavorable disease على طول. Till 10 years ago to 15 years ago, we know this information. You know, when I was a resident, I know this information, that class 1 and 2A are good, class 1 or 2B are unfavorable disease. So what is added? It added that even some classes of 1A and 2A, but they have bulky disease or ESR high, still they are unfavorable as if they are B. So not only the B symptoms are dependent on it, we are now dependent on more and more objective markers, because still the B symptoms is a subjective marker. This is not an objective marker, this is a subjective marker. We depend on many groups like the Germinal Hodgkin Study Group, the European Organization of Research and the Treatment of Cancer, the National Comprehensive Cancer Network, or NCCN, to classify this early stage. So the early stage, according to all of them, will be divided into favorable or unfavorable according to the age, but this is an erotic criteria alone. But for the Germinal group or NCCN, they do not depend on the age. The bulky disease, definition of bulky disease, the ESR, the extranodal involvement, the number of lymph node enlargement, and if any of these is available, even the patient is class 1A or 2A, the patients will become unfavorable, or at least favorable, unfavorable, according to the classes of the which society will depend upon. So the patient to become class 1 or 2 favorable disease, he must be painless, he must not be old age, he must not have larger amount of groups if it's stage 2. Of course, it's stage 1, one group only. If it is stage 2, it will be less than one group. Number 2, what are the definition of lymph nodes group? For the Ann Arbor, it is easy. Every group of lymph nodes is considered a lymph node group. So right cervical, supraclavicular, right subcostal, right axillary, left cervical, supraclavicular, left axillary, mediastinum, right hilum, left hilum. Any one of these is considered a group. So having 3 groups is very easy. But for the germinal groups and the European group, no. They put the right cervical and subpectoral and intercostal together. They put the left cervical and left infraclavicular or supraclavicular together. They put mediastinum and the hilar together. So it becomes easy, because if you use Ann Arbor, always the patient will have more than 3 groups, and always the patients will be unfavorable. But now we understand that the presence of mediastinum and the hilum at the same time is not a strange thing. They are the same thing, because they are grouped together. All of this is for the group 1 and 2, or we call it the early stage. What about the 3 and the 4 is the advanced stage. We depend on another points. No more bulky disease, because it is above and below the diaphragm or infiltrating the bone marrow. خلاص. We do not depend on these things. We depend on another thing, like albumin, like hemoglobin, like age, like sex, like stage 4 disease, like the presence of leukocytosis, like stage of lymphopenia. These are much and much more risky. We can use this qxmed.com calculator for the Hodgkin disease prognosis only for patients with stages 3 and 4. Do not apply this to stage 1 and 2, because stage 1 and 2 needs bulky disease, P symptoms, ESR, etc. And usually we'll do what's called Deauville score. And Deauville score, we see how much the dye is taken. So if it is no FDG uptake is taken, this means negative. FDG uptake less than mediastinum, this means negative, and this is 2 Deauville score. If the uptake is more than mediastinum but less than liver, it is still stage 3 considered negative, but in some other groups they are considered positive. So 3 may be positive or negative, but of course 4 and 5 are positive. This means that shining is much more than the liver, but less than the baseline in the 4th, but in the 5th markedly increase uptake in the liver or new sites. This means market. So Deauville 4 and 5 means relapse or means non-response, while Deauville's 1 or 2 means negative or very good response if it is repeated. And the stage 3 sometimes put with this group and sometimes put with the other group. Next time, inshallah, we will discuss the differential diagnosis and how to treat. Now you understand how the diagnose the lymph nodes and the Hodgkin lymphoma, and what are the difference between subclasses of Hodgkin lymphoma, as a classical and non-classical, how to diagnose this, what are the special issues with doing the beta scan and to diagnose, how to classify patients in stage 1 or 2 using Ann Arbor or other groups like Germinal group or like the European group or like the NCCN group, how to diagnose the favorable and unfavorable outcome of patients with stage 1 or 2 or early stage, and how to classify the patient of stage 4, how they have more or less risk markers. If the patient is having 5 risk factors, the outcome is worse for 5-year survival and 5 relapse-free survival. And if he has 0, it is much, much more outcome, very good outcome. So having patients with bad outcome in stage 4 even makes the prognosis better or worse according to the amount of the Hassen-Clever International Prognostic Score points. Next time we will discuss, inshallah, a differential diagnosis and much go into details of how to treat these patients and why we are making all of this complex classification and prognostic impacts, because it will differ when you treat patients with the marked toxic, highly toxic drugs like the treatment of the Hodgkin lymphoma. You must be very good assuming that I can use less drugs to have the same outcome. It is a universal rule in medicine. Use the least dose of the drug for the least duration to have the best outcome. دايما بندور على أقل كمية من الكيموثيرابي في أقل duration عشان تديني أحسن نتيجة. مش باخد the best outcome على طول giving very high dose chemotherapy and the patient will die due to treatment, ولا هدي less chemotherapy and the patient will fail to induce remission. So we will see this and we'll see the problematic appearance of some kinds of Hodgkin lymphoma and how they are non-Hodgkin differential diagnosis at the same time. By this, we will finish, alhamdulillah, this record. We will stop now the